Hello, everyone, and welcome. Thank you for joining us for today's webinar, Frontotemporal Degeneration, Understanding the Disease, presented by Home Instead and hosted by the American Society on Aging. We will begin shortly, but before we do, a few housekeeping notes. I would like to direct you to the left side of your screen where you will see 5 tabs labeled Speaker Bio, Important Information on Group Viewing, CE Application Here, FAQs and Troubleshooting, and Event Resources. The slides for today's presentation are available for download under the tab labeled Event Resources. You will find information on how to obtain CE credits for this event under the CE Application Here tab, including links to the application and to the step-by-step CE guidance webpage. We have changed our CE application process, and now you will be able to instantly download your certificate after successfully completing the application. Access all your certificates in one place at any time, receive immediate pass-fail results, and complete additional attempts at any time within the 60-day period from the live webinar date. Please be aware that your time is logged. You must view the entire hour-long webinar to be eligible for CE credit and access the application. You will be able to access the CE application a minimum of 2 hours after viewing the event once attendance is received and recorded, although it may take up to 24 hours, so we appreciate your patience. If you are not logged into the webinar directly using the email address you registered with, then you will not be eligible for CE credit as we have no way of tracking your online attendance. If you registered before the live webinar, you will also receive a follow-up email by the end of the business day that will direct you on how to claim CEs and include links to today's slides and recording. You have 60 days from the live event date to complete a continuing education application. If you have any questions during today's presentation regarding the webinar, you can send those to us at any time using the Ask a Question box, and we will do our best to get to those in the last few minutes of today's programming. And now, I would like to introduce Lakelyn Eichenberger, gerontologist and caregiver advocate at Home Instead, to welcome our presenters.
Thank you so much, Victoria. Hello, everyone. Welcome. We're so glad that you are joining us today for a really important topic, frontotemporal degeneration, understanding the disease. A lot of people might not know much about FTD, and I hope you walk away from this webinar with new information and resources to help you better understand the disease, to care for those that are impacted by it, and to support maybe the caregivers or care partners that you interact with in your profession as they support someone living with FTD. So I am definitely not an expert on this, and so I have enlisted the experts from the Association for Frontotemporal Degeneration, and I'm very excited to introduce you to these 3 fantastic guest speakers that we have for today. The first is Esther Kane. She first joined AFTD as its Director of Support and Education in November 2020. Previously, she served as Director of Wellness at Care One Management, a company that provides elder care services throughout the Northeast United States. She brings clinical, educational, managerial, and marketing skills, along with a passion for quality care for those who are living with neurological conditions. Her work reflects a strong commitment to the importance of education and training throughout the spectrum of diagnosis and delivery of quality care. Her work reflects a strong commitment to the importance of education and training throughout the spectrum of diagnosis and delivery of quality care. Also joining us is Dr. Shana Dodge. Dr. Dodge joined AFTD in May 2021 as Director of Research Engagement. In this role, she works to build an activated, empowered community of people impacted by FTD who can make informed decisions when it comes to participating in research, and those values and priorities inform research and regulatory decisions. A licensed clinical psychologist, she holds a PhD in clinical psychology from the University of Hawaii, an MA in psychology from the New School, and a BA in psychology from George Washington University. And then we also have Will Reiter. Will joined AFTD in May 2021 as Education Program Manager. He has worked in the dementia field for more than 30 years. He has an MA in gerontology from SF State University. In a variety of local and regional settings, he's provided direct support and education for those living with dementia, care partners, and healthcare providers. Most recently, he served as the Health Systems Director for the Alzheimer's Association Delaware, New Jersey, and Pennsylvania region. At AFTD, he works to strengthen relationships with clinicians and healthcare providers and creates new resources and education programs to increase early diagnosis and improve access to quality care. So as I mentioned, these three speakers come with a lot of experience and knowledge. I'm very excited for you to learn from them today. So I will start by passing it over to Will. Thanks so much, Will.
Thank you, Lakelyn. Hello, everyone. It's a real pleasure to be joining you. Thank you to Home Instead as well as the American Society on Aging for inviting us to present on this important topic. At AFTD, we really feel it's important for frontotemporal degeneration, or FTD for short, to become just as well known as Alzheimer's disease and other dementias. So thank you to all of you who are listening in to learn more about this commonly misunderstood and misdiagnosed dementia. We have a broad range of learning objectives today. First off, we really want you to better understand how FTD differs from other types of dementia. I've worked for a long time in the aging field, particularly with those with dementia, and I feel like I have a good, strong understanding of Alzheimer's disease. I didn't always have a good knowledge base in FTD over the years, so hopefully you'll leave with that. We're going to talk about some of the common signs and symptoms that are specific to the FTD disorders, as well as sharing approaches and strategies and ways to better respond to the common FTD symptoms. We're going to then move on to talking about experimental therapies. It's really exciting and very hopeful right now in terms of FTD research and potential treatments. So we're going to share some of that hope with you and also talk a little bit about the importance of genetic counseling and genetic testing. And finally, we're going to do a quick overview of how AFTD, the organization that we work for, helps families and also healthcare professionals in terms of services, supports, and education. To get us really all on the same page and some level setting, I'm going to just talk quickly about dementia. I think having talked with community groups frequently over the years about dementia, and you may agree, there's a common misperception in the general public that dementia is a disease. It's a specific diagnosis, when in fact we would call it, a medical syndrome or a medical term that clinicians use when they've assessed a diminishment in cognitive functioning that would include problems with thinking, difficulties with memory, challenges with judgment and reasoning, potentially behavioral or personality changes to such an extent that they interfere with the person's daily life and activities. So it's not a single diagnosis, and many different disorders cause dementia, and we're going to talk about just a few next. The likelihood of developing a dementia certainly increases overall with age, but we'll talk a little bit how with FTD that's slightly distinctly different. So the four types of dementia that I'm going to highlight, certainly many of you know and likely work with people with Alzheimer's disease. It's the most common cause of dementia. 60 to 80% of all dementias are caused by Alzheimer's. It continues to grow both nationally at 5.8 million in the U.S., and I believe it's close to or getting close to 50 million worldwide. And typically memory loss, short-term memory loss, is the most common early symptom. Not the only symptom, but pretty typical. Vascular dementia is roughly 10 to 15% of all dementias when it's purely just vascular dementia, but vascular dementia can be part of what's called mixed dementia, approximately 40% of the time, where the person has vascular dementia and another type of neurodegenerative disorder. Vascular dementia is sometimes caused by a major stroke, a number of mini strokes, or some type of cerebral vascular event or damage. Contrasting that with Lewy body dementia, which is about 20% of all dementias, around 1.4 million people in the U.S., and typically the initial symptoms are motor movement challenges. People are often thought to have Parkinson's initially. There are some distinct differences, and in particular, people with Lewy body dementia can have very vivid hallucinations. So frontotemporal degeneration. So roughly 50 to 60,000 people in the U.S. That's a figure that we believe may be underdiagnosed. FTD, it takes quite a while for people to get an accurate diagnosis, over 3.5 years on average. And sometimes people live with another diagnosis. And so that's a challenge. The most common disorder forms are ones that affect either language or behavior, although there are some movement disorders. And the distinct difference is the age of onset for people with FTD in terms of symptoms is younger. And I'll say more about that in just a moment. Here we have a very colorful brain imaging slide. If you look at each of the brains, the top of the brain would be the front, and the bottom of each scan would be at the back. You can see in the red rectangle a scan for someone with FTD, and you can obviously see that in terms of the scan and the colorations for what areas of the brain are active and functioning well, and those that are not, that FTD impacts very specific areas. So the frontal and temporal lobes, either individually or collectively to start, although with neurodegeneration, deterioration often starts somewhere and then over time continues to develop. Here we see just a very shorthand overview of some of the common symptoms of Alzheimer's and FTD. So if we speak about Alzheimer's, already mentioned short-term memory loss. So often a person will forget something like that they had breakfast that morning, or that their daughter visited yesterday, or that a half an hour ago they asked their spouse, when do I have my cardiology appointment? So forgetting recent events, because Alzheimer's, the deterioration tends to start in the hippocampus, which has to do with storage of new memories. Additionally, there's certainly confusion with person, place, or time, challenges with visual spatial perception or interpretation, and the onset is generally 65 and older, with the risk increasing with age. Certainly, you all know that there are people younger than 65 called younger onset Alzheimer's, but it's less common in terms of the whole trajectory of the disease. With FTD, the most prominent initial symptoms are pretty severe or critical changes in behavior and personality based on an individual's baseline, problems with expressive or receptive communication, and then there are some disorders which initially start as changes and difficulties in movement. The onset of symptoms generally occurs between the ages of 45 and 64. Certainly, people have been known to be diagnosed as young as 28 and up to 80. But the general age of onset is when a person is in their what we would call their middle years, their productive years. So there can obviously be an impact with finances, with family responsibilities that may come into play. Just a quick, brief history. So this is a picture of Arnold Pick, who was a professor of psychiatry in Prague in the late 19th and early 20th century, and he was the first professor of psychiatry. He was the first person to actually describe and identify a patient with FTD symptoms. In 1911, interestingly enough, it was Alois Alzheimer who really described the pathology. So on the cellular level, noticing the PIC bodies, the misfolded protein, and the PIC body as one of the signs and the pathologies of FTD. Then jump forward after a relatively long and dry period to the 90s and 2000s to greater knowledge about the particular proteins which are misfolded with FTD and the genetic variants that can be the cause of genetic FTD. And as I mentioned, currently more and more research trials are taking place. So I am now going to turn the program over to my colleague, Esther Kane, the Director of Support and Education.
Thank you so much, Will, for that level setting and helping us kind of get a grasp of where FTD fits in the dementia space. So what is FTD? And I think it's important to understand that FTD occurs when abnormal proteins accumulate and clump together in the brain cells. And some of the most common proteins that we see are tau, TDP43, and FUS, or sometimes called FUS. In some cases, these accumulations result from a change or variant in a person's genes, and in other cases, we don't yet know the cause. And my colleague, Shana Dodge, is going to talk more about the genetics FTD in her slides and presentation in a few minutes. So frontotemporal degeneration is not caused by a single disease, but caused by a cluster of complex disorders. There are three main clinical presentations of FTD: initial changes in personality and behavior, language and communication, or movement and motor skills. The names of the FTD subtypes or variants are behavioral variant FTD, which is the most common, up to 50% of cases of FTD, primary progressive aphasia, and the atypical Parkinsonisms that you might hear them referred to, or the movement disorders of FTD. So we'll take a closer look at each of these subtypes and go through them a little bit. So FTD presents with damage to the frontal and temporal lobes of the brain, as you can see here on this slide. And science is still learning all that occurs in these parts of our brains. But what we do know is the frontal lobe controls a lot of our personality and who we are. So behavioral variant FTD, where we see atrophy to the frontal lobe of the brain, we see changes in behavior and personality indicative of the disease. So we will see a lot of change in reasoning, control of behavior, problem solving, emotional control, safety awareness, etc. And we're going to talk more about these in the next slide. So in order to be diagnosed with probable behavioral variant FTD, a person will need to present with 3 of the 6 clinical criteria for diagnosis. And the 6 symptoms listed here are the 6 clinical criteria I'm talking about. Apathy is one of the more common first symptoms that we see in behavioral variant FTD. It occurs in about 50% of cases, and it's very difficult for families to distinguish between depression or other issues that might be occurring in middle age. And so very often, one of the most common misdiagnoses of FTD is actually depression. Apathy, though, is a little bit different because although they don't have the maybe get up and go or a desire to participate in activities, they may not be sad or display some of the other symptoms that we would see in depression. So it's important to really get a good clinical workup to understand what is this apathy or is this actually depression and what's happening here. Another very common symptom we see is disinhibition. And behavioral disinhibition is probably one of the more disturbing behaviors for families and people diagnosed with FTD. All of a sudden, they lose their ability to kind of control what they say or what they think, and they just say the first thing or do the first thing that comes to their mind. And very often, these people look really healthy. They don't look as though they have a diagnosis or that they're ill. And yet all of a sudden they're saying really inappropriate things at inappropriate times. We hear from families all the time that one of the first triggers for them was they went out to dinner with dad and he called the waitress, something really inappropriate. And everyone was kind of astonished that that occurred. It was so outside of character for their dad. And that sometimes can be one of the first symptoms that there's something going on. Another big symptom we see is loss of sympathy or empathy. And this is extremely difficult for care partners and for family members because the person loses their ability to almost care. We hear from care partners often that, mom didn't care that I was getting married. She didn't care I graduated from high school. Dad wasn't as excited as I thought he was going to be. And that makes it really difficult for the family who are helping to care for the person because they start to lose that connection and that emotional relationship that's so important in all of our relationships. We also very often see compulsive or ritualistic behaviors, and there tends to be a lot of changes in eating habits or diet. And then most of all, we see a lot of deficits in executive functioning. People with behavioral variant FTD very often score very well on the cognitive tests that we typically use for people with dementia, but they are not performing well at home, and there's a lot of financial misuse that can occur and other safety issues that happen. So it's really important to get a good neuropsychological evaluation and not just rely on the mini-cogs or some of the other tests that are really developed for Alzheimer's disease. So we also see in FTD, or frontotemporal degeneration that occurs in the temporal lobes of the brain. And this is typically where we see the primary progressive aphasias of FTD. We once thought that BVFTD was the most common diagnosis, but we are seeing more and more people being diagnosed with primary progressive aphasia. And what you'll see is that as the atrophy occurs in the right and the left lobes of the brain, we start to develop issues with language and communication. The three types of primary progressive aphasia or non-fluent agrammatic. And in this particular type, we see individuals begin to lose proper grammar, especially their ability to use small connecting words, but they have preserved language comprehension. So they understand what they're asking for, but the words aren't coming out of their mouth the way that they're thinking them. And that's really important when you go to caring for people with primary progressive aphasia to understand, because although they may be presenting as having not maybe mentally understanding what's happening, it's more an issue of the words coming out of their mouth and not a cognition issue. And you need to be really cognizant of that and how we care for them. In semantic variant PPA, we see anomia or the inability to recall names of objects, and very often there's a lot of repeating of words and sentences. And then in logopenic FTD, there's difficulty with finding the right word when speaking or difficulty with repeating phrases. But in all of the primary progressive aphasias, we see a loss of language and the ability to communicate. So as we continue to look at the FTD and the brain, it's important to understand then where these motor symptoms and these functions occur. And corticobasal syndrome and progressive supranuclear palsy are caused by the same protein clumpings that we see in the other FTD subtypes, but very often they're occurring a little bit deeper in the brain, which is why we're getting different symptomology that's occurring. You may have very often heard of these as atypical Parkinsonism types of diagnoses. And in some cases, there's not a lot of dementia that occurs, and in other cases, there's a lot of behavioral cognitive symptoms that we see. In corticobasal syndrome, we tend to see a lot of alien limb phenomena or neglect on one whole side of the body, which is pretty indicative of the disease. And there's increased gait and balance problems. And then in progressive supranuclear palsy, we see a lot of frequent falling. There's a very specific eye movement or changes in eye movement that are very indicative of the disease, along with neck stiffness or posturing, shuffling gait, and other symptoms that are very similar to Parkinson's disease. And since the discovery in 2011 of the C9orf72 gene mutation, we've learned more and more about the correlation between FTD and ALS. It has really transformed a long-held belief that ALS is purely a movement disorder and that FTD is purely a cognitive or behavioral form of dementia. We are seeing more and more cases of FTD, ALS within our communities, and people are reaching out to us. And this really creates a very unique situation for care partners. AFTD does have a support group specifically for those with AFTD and ALS, and I'll talk a little bit more about how you can access our support services in a few slides. But it's important to recognize that when people have an FTD diagnosis and an ALS diagnosis, the families are really struggling with a balancing act of the services and supports that we want to give somebody with an ALS diagnosis may not be appropriate for somebody with FTD. They may not have the cognitive functioning to be able to handle a ventilator or a tube feed. They may not want a ventilator or a tube feed. So early intervention of palliative care is really important to help understand the wants and desires of the family and person diagnosed to really provide them with the best care possible. So I want to talk a little bit about management strategies and understanding what it's like to live with an FTD diagnosis. So a few years ago, AFTD did a study on the costs of FTD with responses from nearly 700 care partners and caregivers. Published in the Journal of Neurology in 2017, the study concluded that the average annual costs associated with FTD are roughly double those of Alzheimer's disease. 12 months prior to diagnosis, overall household income ranged from $75,000 to $100,000, where 12 months after diagnosis, income declined to $50,000 to $59,000. And 1 in 3 caregivers had to stop working after a loved one's FTD diagnosis. And this really just shows the economic effect of a diagnosis, and it really is contributed to by the early onset nature of the disease. Most of these people being diagnosed are still working. They're still at a time in their life where they're saving for retirement and for their future. And the impact of this diagnosis at this age is extremely devastating to families. FTD is a complex disease. Upon a loved one's diagnosis, care partners face emotional and practical challenges that can be overwhelming and isolating. Support groups provide a resource, an outlet, and a place to collect and share thoughts with others who understand. Having people who understand the diagnosis as well as the disease provides a safe place for caregivers to discuss their feelings. And I know Will is going to talk about this a little bit, but I can't plug support groups enough. If you have patients or people who are looking for support, send them to our website or our helpline, and our trained staff would be more than happy to assist them in finding the right support, education, and information for them. So unlike many other dementias, FTD frequently occurs in middle age, meaning there are often children at home. When any parent faces a serious illness, their young children and teens need support and flexibility, as well as lots of love and understanding. Few situations can be as stressful on a family as losing a parent to a degenerative brain disease. FTD is a less common disease with challenging symptoms that can cause considerable impact on the family. As FTD progresses, it creates ever-changing obstacles and unique challenges for family to manage. Meanwhile, children grow and change. And it's really important that healthcare professionals recognize the fact that there may very well be kids and teens at home. Most of the families we talk to have kids and teens, or they have young adults in college, or people just starting out in life who really are severely impacted by this diagnosis. Neuropalliative care is a new and growing field within neurology that focuses on improving the quality of life of patients with serious neurological illnesses. And one of the biggest obstacles we hear from families all the time is they're given a diagnosis and they don't have the support that they need, or the medical reviews. They come back to the neurologist in a year and they just get a follow-up cognitive test and they're kind of lost. And neuropalliative care and palliative care in general offers a supportive model to help carry these families through this diagnosis and offer them the support that they need, especially when it comes to making difficult decisions about quality of life. So although it's a new and emerging subspecialty, those patients that we have and those families we talk to who are able to benefit from it can't speak highly enough about the value of these services for them as they are navigating this disease process. One of the things that we talk about is because FTD has no FDA-approved treatment, caring for a person with FTD requires a team approach to manage the complex, ever-changing symptoms a person experiences. Care teams can consist of family, friends, and community support, a medical team, social workers or therapists, speech and occupational therapists, elder law, palliative care, and hospice services. No person can care for a person with FTD by themselves, and they need support networks around them to help manage the disease. And not only do they need support networks around them to manage the disease, but they need supportive healthcare professionals who understand the disease and are willing to learn and support them in the midst of it. It's very frustrating for people with FTD when the professionals they reach out to for support need to be educated by them and advocated to by the person diagnosed to better understand the disease. So I really want to congratulate you and thank you all for coming to this presentation today, because it's so important to understand what these families are experiencing and what's going on so that we can better support them as a healthcare community. We all know about person-centered care, but in FTD, it's really important to understand that no two people with FTD necessarily present the same. If you've met one person with FTD, you have met one person with FTD. And we hear a lot of people like to lump all people with FTD together into one big ball, and that's not always the case. Some people might have compulsive behavior and they might have issues with eating and they might have disinhibition, but they may not have any aggression at all, or they may not display any symptoms of language issues for a little while. And so it's important to really do an individualized assessment of the person and really understand where they're at with the disease, where their deficits are, how can we support them, and what do they need. And the more clinicians can just understand that every person is different with FTD. The symptoms may look different depending on what's occurring within the brain, and we're going to support the person and not necessarily the disease is so important to offering comprehensive care to the FTD community. One of the things that I think are one of the biggest struggles is really managing some of the behaviors that happen within FTD. Some of the behaviors can be really difficult for caregivers, especially as they are not necessarily ready or thinking they're going to be taking on this role or responsibility. And so the more that we can support them in managing behaviors or understanding behaviors as a symptom of the disease is really important. And I always tell care partners, and we really echo that the behavior is not on purpose. Even though the person looks healthy, and very often a newly diagnosed person with FTD appears really healthy and as if nothing's going on, there are changes occurring in their brain which is causing them to display or behave the way that they're behaving. And the more we can understand that it's not purposeful and it's not for a reason, it seems really simple, but it makes a big difference for all care partners to better provide more comprehensive care. Another thing to consider is this behavior hurting anyone? Is anyone being affected by this behavior? Sometimes it might be annoying, or sometimes the behavior can be stigmatizing, but nobody's actually being affected by this behavior. So we really want to take a look at that and look at quality of life for the person diagnosed and how can we better support them. And the other thing is we want to modify. You know, you can't expect somebody with FTD to go to a wedding with 900 people and be away all weekend and not sleep and then have them be the same. You may need to modify what that event looks like and kind of take different steps. And we're going to talk more about that in a little bit. IFTD does have these awareness cards, and we always recommend that families take advantage of them, and even healthcare professionals recommend them often to their clients because these awareness cards allow them to kind of say to people around them, hey, my loved one has this diagnosis. We have quite a few people with FTD who use the cards themselves and say, hey, just so you know, I have this diagnosis, so my language might I might struggle with language. I might say things that are inappropriate. Here's why. To learn more, go to the AFTD. And this is really important to breaking down some of the stigma that's associated with an FTD diagnosis. When we're looking at managing compulsive behaviors, which is another very common symptom, we're going to follow the steps that we know to do in good quality dementia care. We're going to assess the behavior. What's occurring? Why is it occurring? Can we identify triggers? Maintaining a routine is really important, and daily physical activity really helps encourage the person to kind of diminish some of those compulsive activities. I had a client who had reached out to me, and his wife kept going to the mailbox repetitively during the day when he would start working. And every day he would start work, and then she would keep walking to the mailbox over and over and over again. And it was a safety concern for him because he didn't want her to get hit by a car. He was trying to work. He was concerned at her safety. But he realized that part of the behavior started when he went away to go work. And so what he did is he actually started her on a new activity before he went to go start his work, and had her fold towels. And then she started folding the towels, and that compulsive behavior to go for a walk out to the mailbox compulsively throughout the day actually changed, and it stopped because he figured out that she needed something to do. When he went to work, she didn't know what to do with herself, and so she started this kind of pattern of walking. And so it's really looking at the person and trying to figure out what's causing this behavior and what's happening, and how can we better modify the environment to make the person as successful. So what we say all the time is you can't change the person with FTD, but we can always look at the environment to make the person with FTD more successful and have a better life experience. So we want to think about things like minimizing noise and stimulation, reducing clutter and distractions, simplifying social situations, and seeing what can we do to make this environment a more calming environment so the person can be more successful. I had a person with FTD who works with our community quite a bit, and she was talking to me about how she had a modified Christmas. She normally had gone to Christmas all the time. All the kids would come to her house. She has 7 kids, and they would all come to her house, but it was getting really overwhelming for her to manage and to handle, and so she ended up changing Christmas. And so then in the month of December, they went to a different child's house at different times, and they had one-on-one time, and it was a much calmer environment. And the person with FTD was able to have a much better experience because it was less distracting. It was a smaller environment for her to engage, and her family had a better experience because they really got to be able to enjoy time with their mom without their mom being overwhelmed and having to leave early. So we always recommend look at the environment. What can we change in the environment or the situation to help the person with FTD be more successful? And now I'm going to turn this over to my colleague Shana Dodge to talk a little bit about what's happening right now in research.
Thank you, Esther. So while there are no current FDA-approved treatments for FTD, the last few years have seen a huge increase in opportunities to participate in FTD research and the availability of studies testing experimental therapies for FTD. This includes the recent emergence of clinical trials for disease-modifying therapies that have the potential to actually slow or stop the progression of FTD, as well as symptomatic treatments that can potentially help improve a person's quality of life, observational studies where scientists can better understand the course of FTD, and care partner studies where the study intervention is supporting other people in the life of the person diagnosed. Between these options, there are opportunities across the range of people impacted by FTD to contribute to our scientific understanding of the disease. People who participate in FTD research report a number of reasons why they do so. In some cases, it helps them learn more about FTD. Some have the altruistic perspective where they want to help future generations. Some say it helps them take a more active role in their healthcare journey. A lot of people find it grants them access to specialized interventions, assessments, or clinicians who may not be available in their regular course of clinical care. And some of these research studies do have the potential to improve one's condition or quality of life. Notably, patients and families often rate their healthcare provider's opinion as the most important factor in deciding whether or not to pursue research opportunities, or whether they're even aware or informed that these opportunities exist. I'm going to talk briefly about FTD genetics, since as we'll discuss shortly, genetics and FTD research are inextricably linked. Approximately 40% of people with FTD have a family history of FTD or a related disorder, and these are considered to be familial cases. A subset of familial FTD cases are caused by an identifiable change in a single gene that was inherited from a parent. All known genetic forms of FTD are autosomal dominant, meaning that if one parent has an FTD-associated gene, the child has a 50% chance of inheriting it. 3 genes cause the majority of genetic FTD, and these include C9orf72, which is the most common gene associated with hereditary FTD as well as ALS, GRN, or the progranulin gene, and MAPT, or microtubule-associated protein tau. Variants in other genes have also been described, such as VCP and FUS, but they're much rarer than the 3 mentioned above. In most cases, FTD is a sporadic condition where there's no known family history of dementia or a neurodegenerative disease. While there are ongoing trials for sporadic FTD, when the underlying genetic cause for FTD is identified, such as protein accumulation caused by a genetic variant, not only are researchers more confident of the correct diagnosis, but the underlying mechanisms causing FTD are better understood. Thus, many current clinical research trials are targeting FTD. Because these trials are targeting the underlying cause of the symptoms, there is the potential to stop or slow the progression of the disease itself. This is a list of some of the active clinical trials underway, and you'll see that these studies are targeting FTD caused by GRN and C9orf72, and trials for these and other genes are in the planning stages. Researchers believe that what is learned from these trials will have implications for FTD caused by other genes and sporadic FTD. And while there is incredible momentum in FTD research right now, one of the biggest challenges is finding eligible participants. Anyone interested in better understanding their risk for FTD and whether they may be eligible for the trials I mentioned or future trials can meet with a genetic counselor. In some cases, the genetic counselor may recommend genetic testing, but genetic testing is never a required part of genetic counseling. In a small percentage of individuals with no family history, a genetic cause is identified. Therefore, even individuals with no family history could consider meeting with a genetic counselor. Undergoing genetic testing also does not commit anyone to finding out the results of the test. If finances are an issue, there are options for no-cost genetic counseling and testing. For more information on FTD genetics, genetic counseling, privacy and insurance considerations, no-cost genetic testing options, please visit AFTD's website. There are ways for both families and healthcare providers to stay up to date on the ever-changing landscape of FTD research opportunities and scientific breakthroughs. The FTD Disorders Registry, co-founded by AFTD and the Bluefield Project to Cure FTD, is a resource for people impacted by FTD. Healthcare professionals and others can sign up to receive general communications about FTD research. The registry itself is a secure online platform that connects people impacted by FTD to research opportunities. Participants' personal information is never shared. Another way to stay up to date on scientific advances is by signing up for AFTD's newsletters. A final way that I'll speak to about contributing to scientific breakthroughs in FTD is through brain donation, which is one of the most valuable contributions to research a person diagnosed and their family can make. It's a difficult, sensitive topic that should be discussed early rather than waiting until crisis or end of life. The brain donation facilitation process is much smoother when it started early. Brain tissue accessed through brain donation has led to major scientific findings in FTD. For families, it can give the final diagnostic confirmation that isn't available except through post-mortem analysis and can serve as an explanation for the disease symptoms. It also allows a person to participate in research who may not have been able to do so during life. There are a number of ways that brain donation can happen. One is through enrolling as a research participant in life through studies such as the All-FTD Natural History Study. Another is through nonprofit organizations such as the Brain Donor Project and Brain Support Network. The links to these programs are on the slide and can also be found along with additional information on brain donation on AFTD's website. The scientific landscape of FTD has changed significantly in the last several years, and families need to know about these advances. There are opportunities for everyone to advance the scientific understanding of FTD, and for some to potentially improve their own quality of life or functioning for a disease with an urgent, unmet medical need. Clinician opinion is a key factor in considering genetic counseling and research participation. However, people with FTD and their families should consider genetic counseling before pursuing genetic testing. The FTD Disorders Registry is a way to keep informed about research opportunities and for people impacted by FTD to find opportunities to participate in research. We encourage you all again to sign up for AFTD newsletters to stay informed about research opportunities and developments. And I will hand things back over to Will Reiter to discuss AFTD resources.
Thank you, Shana. So I am going to do a really super fast whirlwind tour of AFTD resources so that we'll have some time for questions. So you should know that the Association for Frontotemporal Degeneration has been around for over 20 years as the largest nonprofit voluntary health organization focusing passionately on FTD and helping families, advancing research, educating and informing healthcare professionals, and advocating for federal and state services and supports. This is really just a snapshot of some of our resources, and I think primarily I'm going to emphasize a few of these. So we have a helpline both via email at info@theaftd.org or phone at 866-507-7222. And individuals with FTD, families, researchers, healthcare professionals contact us regularly for to answer a variety of questions. So please don't refrain from reaching out to us. Our two websites, the general website, www.theaftd.org, has a wealth of information, and you really have to take a closer look to find all of the places that you can access information education. We also have a specific website for kids and teens who are in a family that is impacted by FTD. Already mentioned our e-newsletters, our Family Help and Hope. I'll talk in a moment about our healthcare professional focus, Partners in FTD Care newsletter, as well as a variety of pamphlets and booklets that can be accessed for free by going to our website or contacting our helpline. Something that every healthcare professional should know about to share with families is we are fortunate each year to offer a number of grants. We have a respite grant for family caregivers who live with someone with FTD and are not, getting compensation for care in any other way. We have a quality of life grant for people with FTD, as well as grants available for people who want to attend our annual conference. And then Esther mentioned we do have FTD-specific support groups across the country. There are some that meet in person. There are others that are virtual. We also have national groups that are specific to certain disorders or certain groups of caregivers, and those can all be accessed. Information about those can be accessed on our website. We also have the Partners in FTD Care Journal, which is a quarterly e-newsletter that's specifically targeted to bring healthcare professionals, whether you work in a clinical diagnostic treatment center or in a professional care setting, to better understand the complexities of FTD, the disorders, and how to manage and respond to symptoms. These are just an example of 3 about genetics, about what families need most after a diagnosis, including a handy-dandy 2-page national FTD resource list that anyone could find a benefit from information on, and then a newsletter that we created specifically for facility-based care providers, critically important information. Here's our QR code to sign up for newsletters. Again, our helpline information. We do a number of education programs every year. Coming up in less than a month is our annual conference, which is both being offered in person in St. Louis on May 5th. It's a full-day conference, or can be accessed virtually around the world. We have people from all over the world that have joined us for our annual conference. It's free. There are a number of sessions interested to both families but also healthcare professionals, and our keynote is Dr. Bruce Miller, who is an expert, an internationally known expert in FTD. Additionally, tomorrow, we are offering, if you're listening to this today on Wednesday, April 12th, we have a live webinar specifically for healthcare professionals that offers 1 CME or 1 continuing education credit for social workers, nurses, psychologists, as well as doctors. It's on behavioral variant FTD treatment. If you go to our general website, both for the conference and or this program, at the AFTD.org. Across the top, you'll see a scrolling of those 2 programs. We'd love for you to get involved, either by sharing information with others, helping us to raise funds. We really appreciate healthcare professionals becoming part of our volunteer network in terms of leading or co-leading a support group and other opportunities, or joining us to be an advocate for change. So I'm now going to end the program and turn it back to Lakelyn, and I think we have some time for questions.
Yes, we absolutely do. First of all, thank you all so much for such incredible information. There's lots of comments coming in that are saying, thank you for this information. This is new to me, or this is great reminder. So I know that a lot of people are taking away great information, and I love all the resources that you have, and I hope folks will check out your website and the helpline and the support groups, and then pass it along to those that they're working with, or if it's impacting their families. Hopefully this information is helpful. So yes, we do have time for some questions, and there's some good ones that are coming in. And so I'll just say the question aloud, and between the 3 of you, you can figure out probably who's best to answer what question. But the first question is, how long should the individual experience the symptoms before being officially diagnosed? Do you have any thoughts on that?
I can answer that one. I don't think that there's a specific time that somebody should experience the symptoms before they're officially diagnosed. I think any change that you're seeing that's significant enough to alert a family warrants you reaching out to your primary care physician and or a neurologist to get further evaluation. Sometimes FTD can be difficult to diagnose because some of the symptoms they look like other diseases, right? So apathy may look like depression, and so it's not unreasonable that people are misdiagnosed. But I would say that as soon as you start to see symptoms, I would talk to your medical provider. To get an accurate diagnosis of FTD, you're obviously going to undergo neuropsychological testing to see what's happening within your behaviors. If there's language issues, there's usually going to be a speech therapy evaluation. There's going to be CAT scan, hopefully MRI testing going on, and more we're seeing PET scans happening to be able to get a more accurate diagnosis. And if you go to our website, there's a long list of centers that actually specialize in FTD diagnostics. And many people do find that they get the most accurate diagnosis, although I will say that sometimes the wait to get into those centers can be pretty long.
And Lakelyn, I just want to jump in and mention as well, 2 resources that we have that you can access, I believe, by a website or calling helpline is a symptom checklist for BVFTD, as well as a symptom checklist for primary progressive aphasia. They're both, I believe, Esther, available in Spanish. And one side is for a family member to really be looking at like these challenging behavioral symptoms or these occurring. And then the other side is really for a clinician or a doctor that they're seeing to really get a perspective on the symptoms and how they relate to FTD. And it's really quite valuable for families to start with that if they are experiencing these symptoms.
Those are really great resources. And I think in your answers, you answered a few other questions that folks had about, how do they diagnose? And so appreciate those additional insights. And I love that you have on your website, places people can seek out if they're looking for a diagnosis, because I know that's sometimes the hardest place to start is, who do I go to? Who do I send my loved one to if I think that my loved one is experiencing symptoms? So thank you for information.
Yeah, it's one of the challenges that we certainly face in terms of a person, especially who's starting to exhibit those behavioral symptoms, is I think in general, let's say you go to your primary care doctor, behavioral symptoms, I think for our society, but also for the medical field, are sometimes hard to distinguish and assess, and a person might be more likely referred to a psychologist or a psychiatrist who doesn't have a neuropsychiatry or a neuropsychology background. And that's how people initially get diagnosed with depression, but then the depression medications don't help, and the symptoms get worse. And so we're really trying to educate healthcare professionals as well on what distinguishes FTD from other disorders. And that's why we're focusing right now on BVFTD.
I think one of the things too is that FTD it's unfortunately progressive. And so you will see continued decline in the person who is diagnosed. And so as new symptoms arise, even if the original diagnosis was depression, you always want to talk back to your clinicians and see what's going on. Although the different subtypes are diagnosed by the first presenting symptom. So if your first symptoms are behavioral, you tend to be diagnosed with behavioral variant. If it's language, it's a primary progressive aphasia. And if they're the movements, they're typically first diagnosed with the movement disorders. Very often, all people with FTD end up having issues in behavior, movement, and language at some point within the disease process. So even if the original diagnosis doesn't make sense, keep talking to your physicians, keep letting them know what's happening with the changes. You're going to be more likely to get an accurate diagnosis sooner.
That's great information. And I think there are some questions that have come in, about the different types of FTD and how, it's kind of confusing. How does this type differ from that type? And so I think that's great information to know that's diagnosed by, those first symptoms that present. So that's very helpful. And kind of along the lines of this same conversation, there's been several questions about, is there kind of an average prognosis, or how long does someone usually live with FTD? I know when we look at other types of dementia, it really does vary. So I would imagine maybe in FTD, it's similar, but do you have any information on that you could share with the audience?
So we typically say about the prognosis is 7 to 10 years from the time of diagnosis, but because diagnosis can take 3.5 years on average, sometimes longer, it is hard to tell. We have people with FTD that we are very close to within our community, and they've had the diagnosis for 20 years, and some people who it progresses really rapidly. We typically say that if the symptoms are changing pretty rapidly, it may be a more rapid onset and progression of the disease, whereas if the symptoms are changing slower, the disease tends to progress slower.
Hmm. That's very helpful information. I know we only have 1 minute left, and I need to turn it back to Victoria for some last instructions. But I just want to say thank you again to all three of you for joining us and sharing such valuable information. And I know there was questions about, like, are the slides available? Is this recorded? The answer is yes. So I hope that you all will revisit this information and check out the AFTD website, because there's just so much great information out there. So thank you all again, and I'll turn it back to Victoria.
Thank you so much, Lakelyn, and it's been such a pleasure having you all with us today. We want to thank Home Instead for bringing this webinar to our audience. Please be sure to check out their upcoming webinars at www.asaging.org and register for those in advance. If you have any questions about the webinar, please feel free to email ASA at info@asaging.org. You can also go to our website, like I said, to register for those upcoming webinars. They are available for CE credit for a full 60 days from the live event date. So if you care to share with anyone you know that might be interested, please do so. Thank you again, Lakelyn, and the wonderful team at AFTD. Thank you, Home Instead, and we hope you will all join us again soon.